Hey guys, welcome to Medifaction. Today, let's learn about Cushing syndrome. So, Cushing syndrome is also known as hypercortisolism. So, before moving into detail, let's learn what do you mean by cortisol. So, here you can appreciate the adrenal gland. The adrenal gland consists of a capsule, a cortex, and a medulla. In the adrenal gland, the 75% comprises of the cortex and the rest 25% is nothing but the medulla. So in the 75% of the cortex we have the zona fasciculata which secretes the cortisol, and here the aldosterone synthase is absent. However, the cortisol has to be inactivated to cortisone, which is done by the 11 beta hydroxysteroid dehydrogenase type 2 enzyme. But in certain conditions, there will be absence of 11 beta hydroxysteroid dehydrogenase type 2 enzyme. Which condition is that? It will be leading to AME, which is apparent mineralocorticoid excess. So because of the deficiency of the above mentioned enzyme, there will be inherited deficiency leading to AME, which is apparent mineralocorticoid excess, which is an autosomal recessive condition, and this leads to increase in cortisol because it is not getting converted into cortisone. So what happens then? Then there will be increased mineralocorticoid actions such as salt and water retention, hypertension, low potassium, renin and aldosterone, and also alkalosis. Now let's try to learn about the cortisol relations with protein metabolism. So cortisol acts on protein metabolism, resulting in low protein synthesis, high protein catabolism, so which will lead to muscle wastings, and there will be low amino acid uptake and transports to liver. We all know that amino acid is the basic unit of proteins, and there will be low intake of amino acids resulting in decreased protein synthesis, and also all these get transports to the liver, and in the liver there will be high amino acids. So there is a high amino acid in blood, especially alanine. So what happens? This alanine gets transported to the liver and there will be gluconeogenesis, that is, the amino acid is converted into glucose, and there will be liver protein synthesis also. Now let's see how it affects on the carbohydrate metabolism. The glucagon, the alanine and the FFA, that is the free fatty acids, undergoes gluconeogenesis. And also in liver level there will be high hepatic glucose output and also insulin resistance, and bone development will also be affected. Now let's see fat metabolism. There will be significant lipolysis and there will be redistribution of fat leading to buffalo hump, as we can appreciate here, and moon-like faces, just like this. So these are due to redistribution of fat. Now some other relevant changes based on ophthalm, that is related to eyes. There will be glaucoma and cataract. In some patients there will be gastrointestinal tract problems such as ulcers and cardiovascular system problems leading to hypertension, which in turn results in, right here you can see, left ventricular hypertrophy. This is a normal heart and this is how a heart with left ventricular hypertrophy looks like, and there will be significant salt and water retention, which I have already mentioned, and there will be decreased linear growth and also anti-inflammatory actions. So now let's move to the topic per se, Cushing syndrome, otherwise hypercortisolism. So when we are looking the classification, there is endogenous Cushing and also exogenous Cushing. So in endogenous Cushing, there are ACTH dependent type and also ACTH independent type. The ACTH dependent type comprises the 90%, so it is the most common one, and the ACTH independent only comprises 10%. In deeper, the ACTH dependent type is again divided into pituitary cause and also paraneoplastic cause, in which the pituitary cause is the most common, comprising of about 75% cases, whereas the paraneoplastic only has 15 cases approximately. So the most common cause of Cushing syndrome is pituitary adenoma. Turn off chart. We know that there are microadenomas and macroadenomas, in which the microadenomas are most common. So what happens when there is a pituitary adenoma? It will produce ACTH, and this causes Cushing's disease. Speaking about paraneoplastic cases, it will be causing ectopic ACTH production. So this kind of ectopic ACTH production is seen in certain malignancies such as squamous cell carcinoma of lung, which comprises 15%, then some carcinoids such as bronchial and pancreatic carcinoids, then also it will be seen in medullary thyroid carcinoma, and rarely in pheochromocytoma. Then we have the ACTH independent type. As I told earlier, it comprises only 10%. So this ACTH independent usually takes place in adrenal glands. So most commonly it is seen in adrenal adenomas. Rarely it will be seen in adrenal carcinomas and also in micronodular adrenal hyperplasia such as PPNAD, which is primary pigmented nodular adrenal disease. So most common is nothing but adrenal adenoma in case of ACTH independent. Then it will be also seen in McCune-Albright syndrome, and also moving on to macronodular adrenal hyperplasia. So it is usually due to pituitary cause. So there will be increased ACTH and not adrenal cause. Okay, so here will be pituitary cause only. So there will be increased ACTH production, and therefore it will be obviously ACTH dependent. So the most common overall cause is nothing but exogenous cause, but most common endogenous cause specifically is Cushing's disease, as we have mentioned here, which is about 75%. So in infants, there will be mutation actually in the GS alpha, and that results in McCune-Albright syndrome. As I have told you, it is nothing but an ACTH independent adrenal adenoma, rarely adrenal carcinoma, and McCune-Albright syndrome. These are based on adrenal glands. In toddlers, the most common cause is adrenocortical cancer, and in the most common paraneoplastic cause is nothing but small cell lung cancer. There is something called pseudo Cushing's, which is nothing but the hypercortisolism due to stress response. So these are usually seen in obese people, alcoholics, and also people with depression. So this is due to some stress response. And when we are talking about the clinical features, like that means how a person will be presenting in front of us, we check for the high discriminating values. There are some other findings which we will be speaking about, like centripetal obesity. So all those are kind of low discriminating values, but we will be checking for high discriminating values to get accurate diagnosis. So in people with Cushing's disease, they will be presenting with protein catabolism, except in liver, because I have told in the first slide itself, the protein transport to the liver will be increased. So except in liver, there will be protein catabolism, which will be leading to muscle wasting, and there will be proximal myopathy. So how we can identify this proximal myopathy? So these kind of patients will be having difficulty in taking weights. They cannot bear the weight actually. So there will be proximal myopathies. Then there will be facial plethora. It's nothing but skin thinning and loss of subcutaneous fat. The patient will be so thin and kind of skinny. Then cutaneous striae in stomach. You can, if a person, it is a stomach, you will be able to appreciate striae, cutaneous striae like this in the stomach area. Then also there will be bruising. Then in younger ages there will be osteoporosis, which can be appreciated, and also hypertension and diabetes will be also there. So we can remember this with a mnemonic BSP, like bruising, striae and plethora and proximal myopathy will be useful BSP. Then moving on, the most common clinical finding is, as I told earlier, it is centripetal obesity, but it's not a, what is it, it's of a low discriminating value. So we don't rely that on much on the clinical side. So in adults, actually, centripetal obesity plus protein catabolism can be appreciated significantly, but in child or small age citizens, there will be obesity, short stature, and delayed born age. Now, an incidental adrenal mass, actually, it can be Cushing, and also metabolic syndrome. Like people will be coming with acne and hirsutism due to this ACTH production. So also there will be, as I've mentioned earlier, the same thing only. Clinical findings like body fat, there will be redistribution of it. Skinning, there will be thinning. Then bone, there will be osteoporosis. Muscles, there will be proximal myopathy to be accurate. And in CVS, there will be hypertension, which will be leading to left ventricular hypertrophy. And glucose, there will be diabetes mellitus. And CNS, there will be emotional abilities, and there will be less libido is also reported, and amenorrhea in women, and blood and immune response will be low actually, and there will be significant eosinopenia, increased WBC, but as I told, the immune system is weak. They will be prone to infection. Even though their WBCs are increased, their infection, they will be more prone to infections actually. So it's a paradox. And also there are reports of DVT, that is deep vein thrombosis. Also moon phases, which we have seen the picture itself earlier, and edema is also seen in only 30% of cases. In case of childhood Cushing's, in children, actually males are more common than females in presenting with Cushing syndrome, whereas when we are seeing the overall rates, females are more prone. And in children, actually the adrenal causes predominates. So we have already discussed this. Children will be presenting with obesity, increased androgen, and also short stature. And also catabolism, protein catabolism will be less prominent in case of children. But overall, there will be increased protein catabolism and muscle wasting, etc. So in children, actually the radiotherapy is comparably more useful in children. Now let's move on to the evaluation. How can we evaluate a person with Cushing syndrome? So once a patient is admitted, we will go for the midnight serum cortisol or midnight salivary cortisol. So comparably, actually, salivary cortisol is more or gives the best value, because this right here, this midnight serum cortisol, they has some binding protein, this or globulin, increased binding globulin in case if the patient is taking some OCP, or if the patient is pregnant or something, they gives the high value of serum cortisol, which can leads to false interpretation. So ideally we do both the test, both midnight serum cortisol and midnight salivary cortisol as well, but here more reliable is the salivary cortisol. So it's better. Salivary cortisol is much better because we don't expect cortisol in midnight. So we will check, we will evaluate. And when we are checking the midnight serum cortisol, should be ideally or normally below the level of 1.8 microgram per deciliter, or in other terms, when we are checking, it will be, we can say also 50 nanomole per liter. So if it is less than 1.8 microgram per deciliter, we can simply rule out Cushing's. And when we are checking for the salivary cortisol, we will check whether if it is less than 5.5 nanomole per liter, and if it is so, we can rule out Cushing's actually. So how we check this? So ideally we choose morning 8 a.m. We will call the patient. We will check his cortisol level, and if it is too low, we can confirm it is exogenous Cushing. It is not based on endogenous, it's just an exogenous Cushing. Whereas one other method is 24-hour urine cortisol. So I'm speaking about the third method, that is the 24-hour urine cortisol after midnight serum cortisol and salivary cortisol. We are speaking about 24-hour urine cortisol, but it is not performed actually because it's kind of difficult. So we have easier methods, we go for easier things. And we also, and if there is loss of circadian rhythm, we will confirm it is endogenous Cushing's. And one other thing, that is on the day 2, we can check for ONDST, that is overnight dexamethasone suppression test. So how we does this dexamethasone suppression test is like, we will call the patient at 11 p.m. We give them 1 mg of dexamethasone orally, and at 8 a.m. we will give tablets only, so the patient can sleep after taking 1 mg of dexamethasone orally, and the next morning early morning 8 a.m. we will be calling them, and we will check for the cortisol value, and if it is less than 1.8 microgram per deciliter, he is normal, and if it is greater than 1.8 microgram per deciliter, it's sensitive, so we should proceed further. So out of the 3 tests, so we have this midnight serum cortisol, midnight salivary cortisol, and also ONDST, that is overnight dexamethasone suppression test. So out of these 3 tests, we have to perform the 3 tests, and I'm ruling out urine cortisol, 24-hour urine cortisol, because it's kind of difficult. So all these 3 tests is to be performed, and out of these 3 tests, if 2 becomes positive at least, we can confirm it's a positive test. Alright, so which are the 3 tests? One is the midnight serum cortisol, other one is midnight salivary cortisol, and the next one is ONDST, that is overnight dexamethasone suppression test. So also there are some other things to be remembered. That is a patient with PCOS or metabolic syndrome. We need like more specific test, like low dose dexamethasone suppression test here, because in and other cases like pseudo Cushing syndrome, which I have mentioned earlier, in those cases also there will be false interpretation maybe, so we go for LD-DST to get accurate results and to confirm it. So what do we do in this low dose dexamethasone suppression test is that we give some low dose of dexamethasone, that is 0.5 mg, 4 tablets on day 1 and day 2, and on the third day we call the patient at 8 a.m. and we check for the cortisone, and as usual it should be around 1.8 microgram per deciliter. If it is less than 1.8, we can confirm there is no Cushing's and only PCOS or pseudo only, and if it is greater than 1.8, so it will be Cushing's, that too endogenous type. Alright, so next is some of the causes. We check for the ACTH measurement. We check for the 9 a.m. plasma ACTH. So it will be done fully through cold chain process, and if the ACTH is greater than 10 picogram per ml, it is ACTH dependent, and if it is less than 10 picogram per milliliter, we can say that it is ACTH independent. So there are various ways to identify the dependence of ACTH, and if it is other cases, like if it is greater than 100 picogram per deciliter, it may be ectopic type of, and if it is less than 10 picogram per ml, it will be adrenal type. All right, so sometimes there will be some values in between, like in between 10 to 20 or 10 to 50. So it may be some pituitary cause. So we should repeat the test again to get accurate and to confirm things. So if it is less than 10, it may be adrenal. And for adrenal, we should take a CT, and most commonly it will be some unilateral adrenectomy. Adrenalectomy should be done. Otherwise, if the case is that ACTH is shown some greater than 100 picogram per milliliter is given, so it will be leading our suspect to more of ectopic type. So it will be acting on mineralocorticoid. So in the previous slide itself, I have told about the actions of mineralocorticoid like hypertension, hypokalemia, that is low potassium, less protein catabolism, and fractures and hyperpigmentation. All this will be seen, and if it is ACDS dependent, what we should do is we should take an MRI with gadolinium contrast. And there are some possibilities, like if it is a mass is shown on the pituitary of greater than 6 mass, then it is obviously a pituitary adenoma and we should be treating it with some surgeries. So let's see some other possibilities. So ACTH right here, and it is showing greater than 10 picogram per ml, and we are checking. So if it is some greater than 100 picogram, it will be ectopic. As I have told here, it will be ectopic, and we will be doing a PET scan. And if it is giving some value of 10 to 100 picogram per ml, we should take the MRI of the brain with gadolinium contrast, and we will look for the mass, size of the mass. If it is greater than 6 we should go for surgery. If it is less than 6 mass, it will be some incidental, like we should go for inferior petrosal sinus sampling, and at last we will decide upon the size of the, if it is significant mass, we should do surgery, of course. If it is non-significant, we should again go for PET scanning and confirm it. And if there is no mass, any no mass is suspected or no mass is found, we should go for some high dose dexamethasone suppression test, and we should be giving some 2 mg oral dexamethasone. We are giving high dose, no, so it will be like 2 mg oral dexamethasone, and for 2 days, and there will be 50% of suppression if pituitary cause. If no 50% suppression, it's of course ectopic cause, we can confirm it. So treatment is usually transsphenoidal surgery, plus along with that we should do some medical therapy as well with ketoconazole and cabergoline, and other treatment includes meteropin, like it inhibits the deoxycortisone to get converted to cortisone. So then we have glucocorticoid receptor antagonists such as mifepristone, then adrenolite in adrenal cancer. It is usually given in children actually, like fractional external beam radiotherapy. As I mentioned earlier, for children, radiotherapy is kind of effective. And if rarely, bilateral adrenectomy will be done, but there will be some complications such as Nelson's disease, negative feedback test. So I hope you have understood the video. Like, subscribe, and press the bell button for more videos. Thank you. Thanks for watching. Take care.